I'm on a bus on a Monday morning, heading through the center of Barcelona, Spain. I'm on my way to the Department of Health office. I've actually just arrived in Barcelona, and I don't quite have my bearings yet, but I'm lucky to have an expert guide with me.
Say and spell your name for me.
Tino Marti, Tino Marti.
Yeah.
This is my short name.
Okay.
Tino comes from Laurentino. It's an Italian name that is unusual in Spain. But it's the way my father, my grandfather, and grandfather were named. And I didn't keep the tradition because my son is called Ernest.
Oh.
Tino is a health economist who spent time working for the World Health Organization in Kazakhstan and Greece and is currently part of the Analysis and Strategy Office at the Department of Health in Barcelona.
Tino, can you tell me where it is that we're going again?
Now we are going to the Department of Health, that is the regional Ministry of Health in the region of Catalonia. And it's just next to the Servei Català de la Salut, that is the public health insurance organization that is contracting all sort of public service to all sort of providers.
Tino is not only touring me through Barcelona's public transit system, but he's also giving me the rundown on Spanish primary care as we ride.
The system is publicly funded and is under universal health coverage, so everyone is entitled to get public services. You have to understand from the beginning that you are in a national health system, a Spanish national health system, but is completely decentralized at the state or region level.
Barcelona is in the region of Catalonia, one of 17 autonomous communities within Spain that are responsible for the implementation and funding of the primary health system. Now, each region has its own Department of Health, and today my visit is to the Department of Health in Catalonia. The structure here is actually similar to the one we have in Canada, where the federal government sets laws and national standards, but the provincial and territorial governments are responsible for the implementation and delivery of care.
So every region has the degrees of freedom to organize health service delivery. So when you look at primary care, you cannot look at primary care in Spain, because in each region, large countries, they are decentralized.
I'm curious though, because in Canada, like the quality of primary care and the access varies considerably province to province because the funding and the policies are all different. Is the same thing true here, that the
quality.
that the quality varies
Say that we are more
region?
homogeneous,
Okay.
probably, because in the case of primary care, the structure, it doesn't differ that much. So visiting Catalonia will give you a good understanding of what's happening in the other regions, because the structure of primary care is under a Spanish law that sets how a primary care center should be organized.
It's a similar setup to Canada's, but with one major difference. In Spain, when they say universal, they mean it. Access to primary care is guaranteed for all residents. No one is refused care, and everyone has a family health team. And coming from a country where millions of people still don't have a family doctor, nurse practitioner, or somewhere they can get primary care, I want to know, how exactly are they making it work in Spain? Welcome to Primary Focus. I'm Dr. Tara Kiran, and I've been traveling around the world studying health systems with strong primary care in order to bring back lessons that could help strengthen primary care in Canada. So far on the podcast, in addition to touring innovative clinics in Canada, I've brought you along with me to delve deeper in how primary care is being delivered in the Netherlands, Costa Rica, and now Spain. In this episode, we're going to talk about the history of the Spanish primary care system, how the Primary Care Act changed it all, and how exactly they managed to deliver care to 100% of residents in Spain, and more specifically in Catalonia. And then later on, I meet a family doctor who helps me understand Catalonia's information systems and how they've managed to have a patient-facing app where patients have access to their own health data since 2009. Yes, hard to believe, I know. And then in part two, Tino takes me on a tour of some innovative primary care clinics in Barcelona, and I meet the interprofessional teams powering the system. I've decided to travel to Spain because the WHO Europe has made it an official primary care demonstration site. It's recognized in Europe as a country with an outstanding primary care delivery model, and in particular, a country that's been leading the way for decades on team-based primary care. Now, anytime we compare Canada to another country, I'm always mindful that context is different, and aspects of the healthcare system are different too. If we compare Spain's system to our healthcare system in Canada, it's important to note that Spain spends less on healthcare per capita when we look at the total budget, but the percentage of the total healthcare budget that's spent on primary care is about twice what it is in Canada. They also have more doctors, as we'll talk about soon. Spain's countrywide team-based primary care model actually originates from their commitment to the WHO declaration at Alma-Ata in 1978. Coincidentally, the same year Spain became a democracy. If you listen to our episodes on Costa Rica, you'll remember that the tagline of the Alma-Ata Declaration was Health for All by the year 2000. It's a promise Spain has actually delivered on. And the delivery of that promise began with the 1985 Spanish Primary Healthcare Reform Act. It called for the establishment of geographic zones that delivered primary healthcare. Each zone would have a building and a team of family doctors, nurses, nurse aides, pediatricians, dentists, and social workers to serve the people living there. It was a very forward-thinking approach for the mid-'80s. And then in 1986, they made reforms to how primary care is funded to support universal access to primary care. Here's Tino again.
Even in 1985, the system was based on social security contributions. So still only entitled to receive care those that were working and their dependents. But in 1986, so 1 year after the reform, the General Law Act was passed by the Spanish Parliament, so for all of Spain, and this general law changed our health system model from a Bismarckian model based on social security contributions to a national health service model, like Beveridge model, so inspired by the English health system, which is universal and funded by taxes, no social contribution. So this made the transition from the antique regime to the democracy in the sense that everyone was entitled to receive care from this layer of primary care services and all the public hospital that supported hospital work. And this was the universal health coverage. This was immediately activated.
Now, it took Spain about 20 years to fully implement these laws, but it's the strong foundation that the Spanish healthcare is built on.
Sorry. Whew, almost missed our stop.
The Department of Health building is within a set of matching buildings on a sort of campus with streets lined by palm trees. The buildings, they all have beautiful brick and stonework, a classic example of Catalan modernism, a version of Art Nouveau style with neo-Gothic architecture.
We will enter through the Department of Health, but we will go through the internal bridge to the health insurance, public health insurance center.
Inside, it looks more like a church than a government building. All high ceilings, some fully made of glass, with ironwork-clad lancet windows and intricate ceramic tiles as wainscoting. Tino says this campus was built in 1891, and it was originally built to house orphaned children. In another point in its history, the buildings were actually the headquarters for the International Olympic Committee. But now they're owned by the Department of Health.
This is the bridge, yes, to the... So that was the planning, and this is the purchasing now? Okay.
Normally, this bridge is not too much fancy.
Is that also symbolic, Tino?
Yeah, symbolic.
The buildings host a number of offices. We're walking through the Ministry of Health building that does all the planning and implementation of health services. It's attached by a bridge to another similar building for an organization called Servei Català de la Salut, or CatSalut, that actually does the purchasing of the primary healthcare services.
Hello, how are you? Good, I'm Tara.
Okay, Rafa.
Oh, nice to meet you. I'm Tara.
Tino introduces me to Dr. Rafael Ruiz. He's the director of the primary healthcare strategy in the Catalonia region.
But I appreciate you fitting me in on short notice. It's also a busy week. I know you have that big announcement on Friday, which is very exciting. Yeah.
Now, just for some context, I visited Spain in February of 2025. And at the time, the Department of Health in Catalonia was gearing up for a big announcement a few days later. Although Spain has a world-renowned primary care system, in Catalonia, they are constantly trying to make it better, to innovate and to address concerns from citizens where they see gaps in care. A few months before I visited, the Department of Health had announced 25 measures to help improve the entire health system. It was released actually by an expert committee tasked with launching health reforms in Catalonia. And Tino's job is to support the work of that committee. The announcement they were preparing for on Friday was the launching point for the 25th measure, which, in Tino's words, was to upgrade primary care centers to help increase capacity, improve access, increase patient satisfaction, and ensure high-quality care. In fact, they announced a sort of contest for primary healthcare centers to apply to be one of the new upgraded centers. Tino says these upgrades, they're not necessarily just for the building. Really, they're more about how primary care teams organize their services, how they're paid, and how they integrate new technologies into their practice.
Well, yeah, I'll send you the presentation. Don't worry.
Dr. Ruiz, or Rafa as everyone calls him, is here to give me a presentation about how the Catalonia primary care system started, where it is now, and where they're hoping to take it in the future as they move forward on their system reforms. Now, we already talked about the 1985 reforms that completely overhauled their primary care delivery and mandated that doctors work in teams with other professionals like nurses and dentists. But Rafa says it was not an easy task, and those 1985 reforms took 20 years to actually come to fruition. Here's Rafa.
Before that, we had not family doctors, but general practitioners that was not specialized in primary care, and they only work as a part-time in the primary care. And this reform supposed that the family doctors and nurses were involved in teams, in primary health care teams, and they were working the whole day in primary care.
Rafa says in 1990, Catalonia followed suit with its own legislation, called the Catalan Healthcare Act, which created the CatSalut. A reminder that the 1985 Spanish Act sets out a standard for primary care across the country, but how autonomous regions implement that standard can really be different.
In the Catalan model that is not similar as the rest of Spanish autonomous models, we separate financing from provision of services.
This is why there are two buildings on the same campus separated by that bridge Tino and I walked by. Rafa says Catalonia is the only region that actually separates out the organization that does the planning and financing for primary care with the organization that does the purchasing of the services that allow for the delivery of primary care. That's one big difference here. But Rafa says there are lots of similarities between the other regions too.
One thing that is equal for everywhere is that we guarantee the universalization of 100% of people are assigned to family doctors and nurses in these primary health care teams. We have a network of 377 primary health care teams working for the whole 7.9 million people here in Catalonia.
Rafa says every region of Spain is also broken down into catchment areas. Each catchment area has a primary care center or multiple centers based on the size of that area. And the people who live nearby know that they're guaranteed service there. The centers, they're open from 8 a.m. to 8 p.m., and no resident is actually turned away when they show up. Every center houses that interprofessional team who offers care to local residents. And in more urban areas like Barcelona, one center might house 2 or 3 teams to meet the demand from the catchment area. It strikes me as a really similar model to the one in Costa Rica, or what Dr. Madeleine Pesek called the geographic empanelment model. It's also like the public school model we talked about in our episode with Dr. Rita McCracken. Residents are guaranteed access based on where they live. And if demand surges, the government's responsible for increasing capacity so that no one is left without primary care. Now, if you live in the area, you can simply walk in to your local primary care center and you will receive care, regardless of whether you registered beforehand. But importantly, the center doesn't just serve those who are able to walk into the center, but also those who are homebound or receiving long-term care in the catchment area. Doctors and nurses, they do home visits to serve them. To me, this is such an important point. It means the most vulnerable and high-risk patients, they're getting good primary care alongside the rest of the population. And the primary care team, it's truly grounded in the needs of the community it serves. We'll talk more about that in part 2.
Can I ask a question? So
Yes.
the 377 primary care teams, how many doctors, family doctors would be working in those?
It's quite different. It depends on the population they have related, because we have a distribution of different sizes. The smallest one is about 5,000 people, and the biggest is about 40,000. So you can have teams from 5 GPs with 5 nurses to another team that have about 25 or 30 GPs with 30 nurses. It's quite different. We have an average that is the most common, that is about 25,000 people.
So if the average primary care center is serving 20,000 people, what does that team look like?
About 14 general practitioners and 14 nurses, about 2 pediatricians and 2 pediatric nurses, 1 dentist, 12 administrative assistants, more or less, 2 nursing assistants, 1 midwife and 1 social worker. And then in the last years, we have strongly for the new roles professionals in the way we're trying to foster all the health promotion and prevention. So we have strongly for the psychologist, that is the first emotional well-being member, the nutritionist, also the physiotherapist and dental hygienist. This for new professionals are very focused on the prevention and on the community work.
In Canada, psychologists, dietitians, physiotherapists, and dentists and dental hygienists, they're mostly only accessible if you pay privately, perhaps with your insurance or perhaps out of pocket. There are some people for whom the service is covered, but it really varies on circumstance and where they live. But in Spain, these health professionals are part of the primary healthcare system, which is coordinated with public health. The two sectors do a lot of work together, but they do have separate budgets. And Rafa says these new team members are covered under the primary care budget, and they're part of the strategic goal to improve primary care.
And we are working in the strategy for promote health-based, community-based and participative approach, strengthening the prescription and coordinate the prevention, incorporating new professional roles. This was an example of these new roles, community roles, work for autonomy and social prestige of professionals in primary care. This is a hard thing that we have as a challenge, what's happening with primary care professionals, why they are leaving or why they are not choosing primary care as a way to develop their professional life. No? Guarantee also continuity of care between different levels, hospitals and primary care, and optimize also the demand management.
On this podcast, we've talked a lot about the issue of primary care professionals leaving the workforce, or specifically newly trained doctors not choosing to specialize in primary care. I've learned that it's not just an issue in Canada, but also in a country like Spain and many other European countries.
A few months ago, we have a WHO meeting with other European countries, and we were trying to share all the strategies for going through that, and there was all shared problems and shared challenges for everyone, from Finland to Spain and to Greece and Portugal. So yes, it's a huge challenge for us, and I think we must work together for that.
Rafa says that just like we do in Canada, they've got a much harder time recruiting primary care workers in rural areas. That's rural for Spain, of course. And the new generation of doctors, they're looking for more flexible schedules, more work-life balance, and better social benefits. Something a career in primary care doesn't traditionally offer. Sound familiar? Well, if Spain has some of these same challenges as we do in Canada, how is it that they're able to offer primary care to everyone? There's a lot to unpack in that question, but I will say one of the answers is that Spain does have more doctors compared to Canada. Roughly 1.8 times the number of doctors per capita. And they consider that a doctor shortage. I'm not sure where that puts us in Canada, but in Spain at least, it's not affecting patients' access to care.
So I was looking for the statistic and I found a hard time to find it, but how many people in Catalonia or in Spain, do not have a family doctor? Zero.
You
don't even count that.
No,
you're sure that everybody has
that's
one.
That's right.
But how? But aren't some of the centers at capacity? How can they keep accepting people if they?
We have distributed in these areas. All the area have the resources for having a GP and a nurse for every 1,500 people. So they have the resources. It's true, for example, in rural areas, you can have the resources for contracting 6 primary healthcare doctors, and you can only reach to 5. Mm-hmm. And what happened with the other 1,500 people?
Yeah.
Normally, we work sharing these people into the other 5 GPs, and they try to follow this population as his own population.
So they're doing a higher workload.
Yeah.
And do they get paid more now? Or?
Yeah. From 5 years ago, we are paying what we say is escratio, that is a little bit more of the salary for the biggest way. But for example, you have the right to have a family doctor. So if you are living here in Catalonia, you have a family doctor and a nurse. It's a right for them.
Even in a rural area,
no
one will go without care. They're able to go to the center.
No. They should go to the center and have a...
So even if there's a shortage, there will be somebody there.
Yeah. Attention must be done, must be given.
And is that in law?
Yes. Yeah.
The GP and every person has the right to access a family doctor, and you said a family doctor and a nurse, right?
Yeah.
If you're an adult.
If you're an adult.
If you're a children, a pediatrician.
Okay. Oh, I didn't realize that. So family doctors don't see kids.
No.
So it's in the law, though. That's very interesting.
Yeah.
And that's the 1985 law.
Yeah, that's right.
I know I sound a little skeptical here when Tino and Rafa tell me there are 0 residents without access to a doctor or some sort of primary care. But coming from Canada, where almost 6 million adults don't have that kind of guaranteed access, I'm a little bit in awe every time someone from another health system tells me that everyone, or nearly everyone, has access, whether it's in the Netherlands or in Costa Rica or in Spain. In Spain, doctors are paid by salary for 37 hours of a work week. Typical shifts for a doctor at a health center would be 8 to 3 or 2 to 8, Monday to Friday. And if they work after hours or on weekends, they receive extra pay. Spain has created a system where there's a doctor there to serve all people in a community. And if there aren't enough doctors, well, the doctors, they just need to care for larger panels, and staff are paid to work overtime to make up for it. This guaranteed access to a doctor and a nurse is also tracked, as is timely access to appointments. The Department of Health tracks it, and the stats are shared with the doctors and the clinic. So doctors are aware of how many patients in their practice are able to get an appointment in the next 5 days, for example. That access is also something the Department of Health checks in on.
But we have a system that is from the center control management. They try to get an appointment for several doctors in the several areas, and they try 1 day every month in the first week of the month, and then they calculate all the delay.
So there's some secret callers.
Yeah, it's not really a call. It's just trying to get an appointment in the clinical in the electronic device. Yeah?
How do
One of the other ways they can assess access is that, impressively, Catalonia has integrated information systems. That means they can pull data from the patient's journey to different parts of the system to see the whole. They can see things like emergency visits, rates of admissions, how quickly someone got into the hospital, but also how quickly they were discharged. And with access to all that data, you can see things like the impact of care management for people with chronic conditions, or the impact of a caseload of a specific team. You can also compare teams within the same region. The use of integrated data in the health system, both from primary care centers and local hospitals, was something I really wanted to dig more into. And so, I say goodbye to Rafa and Tino.
Thank you very much.
Tino and I will meet up again in part 2 when he takes me on a tour of primary care centers in Barcelona. But for now, I'm headed out to meet with the doctor that Tino has introduced me to, who I hope can tell me exactly how they've built an IT system that allows for the tracking and sharing of information on patients and health outcomes. It's a busy day in downtown Barcelona, and I'm just on my way to go visit Oscar Solans to learn more about the IT infrastructure behind the centers. We're walking by some beautiful architecture, old buildings. I'm going to pause because I need to go check my map to make sure I'm going in the right direction. Spoiler alert, I was going in the right direction. And my map led me to a gray stone building with 6 or 7 floors that was right in downtown Barcelona.
This is an old building.
Yeah.
It's a Harry Potter building, but it's in the center of the city, and it's very interesting for us because it's easy to come from home.
From anywhere?
Yes.
Yeah.
This is Oscar. And like he says, he works in this beautiful building that is reminiscent of Harry Potter. He's responsible for Salut. That's the IT system that integrates and coordinates the functional aspects of the Department of Health's electronic health platforms. And Oscar, he's also a trained physician. I'm a family doctor and also a... Oh, you are?
Yes, yes.
That's great. Do you still practice?
Yes, 3 years ago.
You stopped
With the pandemic.
practice? You stopped 3 years ago.
When the pandemic is finished,
yeah.
I stopped. Because during the last 12 years, I've been working into managing the strategy of health here, of digital health.
That makes sense.
But I will come back.
Oh, you will come back. Okay.
I want to come back.
I think one of the many things that's impressive about Catalonia is their attention to digital infrastructure and their penchant for innovation. One of the things we heard over and over again through our care is that patients and the public are so frustrated in Canada that they don't have access to their own data. In Catalonia, patients have had access to their data in an online health app since 2009. To understand that success, we have to go back a couple of years to 2007, when they implemented a centralized system for doctors to share information on patients.
To resolve and to share information between different levels of care, in 2007 we built a cross-platform named Historia Clínica de Catalunya, HC3, where that allow all providers, all different information systems, to publish or to upload information, and we share this information through this platform.
This HC3 portal, it allows them to upload data from 28 different information systems used by providers in Catalonia to a central repository. This means that a family doctor can use a different electronic system than, let's say, a clinician in a hospital. But the IT system that Salut built can aggregate data on that patient from both records into one central platform in an easy-to-use and digestible way, both for doctors and patients. The data doctors can access includes clinical notes, clinical variables, vaccines, allergies, diagnoses, and different patient markers. A patient might be marked as a chronic complex patient, or PIC, or an advanced complicated patient, which is referred to as MACA. Doctors can share their reports on their PIC or MACA patients for other providers to access.
It's a very interesting for primary care centers, this one. It's a key report that the family doctors And they say to the patient, if you are a chronic complex patient or an advanced complex patient, I write in this report what to do in case of crisis. If you have, for example, failure.
So this is like advanced directives, like
Yes.
whether the person wants to be
Yes.
resuscitated or not, right?
Yes.
Yeah, that's very important. So you can have that.
And we can share through AC3.
Yeah,
so
very
if you are
important.
going to the emergency room, or I call to the ambulance, the ambulance can see this level of MACA. They click here and it appears the peak. And the peak probably say, if I have a discompensation, please I don't want to go to the hospital. I want a doctor at home. And the ambulance don't send the patient to the hospital and send a doctor of primary care center to home. Through this report that we share with all information systems.
Yeah, that's wonderful.
Before the pandemic, they also added other types of crucial information, like clinical imaging and a central repository for prescriptions, which allows providers in all health systems to access a patient's latest prescriptions. About 6 years ago, they also made a deal with the Social Department of Health to start connecting and integrating information from social health centers into the platform as well, like information on home care or teleassistance, kind of like a lifeline in Canada. Now, the ability for a family doctor to see the notes of doctors, nurses, or paramedics who might have treated their patients in hospital is an incredible update compared to how many family doctors operate in Canada, which often is relying on the patient to relay what happened in hospital. The other exciting part here, of course, is it's not just doctors who have access to clinical information that's important for patient care, but patients themselves have access to a lot of this data through a patient-facing app, which unbelievably has been available since 2009.
Then we connect in this central repository all data we can show in the patient portal of La Meva Salut. Is the portal for citizens. Here now we have more than 8 million of inhabitants in Catalonia. Almost 6 million is using now, or he has entered one time into La Meva Salut. More or less, we have 3.5 million users that they use the application usually. Okay.
Oscar is showing me on his screen how La Meva Salut, the patient-facing app, works. The app offers a collection of colorful square buttons that represent the different data and tools patients can see, what Oscar calls microservices.
Is this Cubi Rubik? How do you say this in
Rubik's Cube?
Rubik's Cube?
When the patient clicks through each of the colorful squares on their La Meva Salut app, they can see their own clinical information, including their visit history, laboratory data, imaging results, wait times for specialty care. There's a messaging portal where the patient can ask their doctor questions. Doctors can send them surveys. And the app is also there to support synchronous remote visits or virtual care. But what can't they see?
And can they see the doctor notes?
No,
No, not the doctor
Here
notes.
you can see all the clinical information that we have here, except clinical notes.
Yes.
And the rest is online.
Now, patients in Catalonia, they have access to the app to see their own medical records, but at Cat Salut, they're still trying to make things better. Oscar says right now they're pulling data from 28 different electronic systems, but they want to make it even more efficient.
This is a good system.
Yes.
It allows us to share a lot of information.
Yeah, good
no?
interoperability.
Yes.
Yes.
But it's very expensive. Why? If you want to share another set of data,
Yeah.
we have to build these web services here, but we have to build 28 more web services here and another here. So to share one set of data, we have to build 30 web services. It's very expensive.
Got it. And just to understand, so the one is for all primary care. The 28 is because there are 28 different other electronic health record systems among the other publicly funded providers.
Yes.
Yeah.
So it's okay,
Yeah.
but it's very expensive.
Got
so
it.
we are trying to
Move
unify
everyone to one electronic health
Yes.
record. Yeah.
And we are building now with a microservices strategy.
They're also hoping to move to one system, which will allow them to innovate even more by connecting wearables and rolling out AI tools.
And now we are building another platform to share all information come from the devices or applications of the citizen. Okay. Because we have a lot of applications, a lot of devices, a lot of wearables, and to avoid to connect each application with each information system, we have built this cross-platform when we connect all companies here, and information systems from hospital or primary care centers can select what the information they need, and they collect this information in the information system. But they also have to connect one time to our platform, and we avoid different integrations with different applications. Mm-hmm. Okay, this is our interoperability Catalan healthcare model.
When I first read about Spain's primary care system, I'll admit I was expecting a lot of bureaucracy. After all, here we have clinicians as employees working in government-funded primary care centers. But I was pleasantly surprised to learn that this isn't some stodgy bureaucracy, but that actually they've leveraged their structure to push forward innovations that really keep the needs of patients front and center. I can't help but say it again. Here in Catalonia, they've had a patient-facing app since 2009. It's only been in the last few years that some provinces in Canada have launched that type of app, and I think it's fair to say that most people in Canada actually don't have that type of technological access to their health records. Here in Catalonia, they're thinking about the future, about how they can pull data from wearables like Apple Watches and Fitbits, or use AI to improve care at scale. When I was there, Oscar showed me an AI-supported clinical decision support tool that they've integrated into the electronic medical record in 13 primary care clinics across Catalonia. As a doctor, if I had a question about treating a patient, let's say a patient who was elderly, who had atrial fibrillation, and I was wondering, should this patient be on blood thinners? What are the pros and cons? What do the guidelines recommend? The AI tool actually searches the Spanish guidelines, and then if those aren't available, the international guidelines, to help find an answer in a way that's really trusted for me, all within the electronic medical record interface, so I don't have to go to another portal to figure things out. It was a pilot, but if all goes well, their plan was to scale it in a year to all practices in Catalonia. I love how they're leveraging their structures to innovate at scale. It's something we can learn from in Canada. And yes, their system is highly managed, but interestingly, I did notice that a lot of the managers were nurses or doctors who had actually worked in the system, people like Oscar. And your job is overseeing so much of this. This is a big, big thing.
Yes, but it's, as a doctor, it's very interesting because you help a lot of doctors.
And also it's nice
work.
to put your clinical perspective on what is important. You know that.
Of course, one of the most impressive things about Spain's primary care system is that literally no resident is left behind. Everyone is guaranteed access at their neighborhood primary care center. So next time on Primary Focus, in part 2 of our tour through Spain's primary care system, Tino is going to take me to different primary care clinics in Catalonia so we can see exactly how they make it work and meet the actual teams on the ground. A big thank you to Rafael Ruiz and Oscar Solans for talking to me for this episode. And of course, a huge thanks to Tino for being my expert guide, for helping me organize this visit, and helping me fact check for this episode. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by funding from the MAP Center for Urban Health Solutions, the St. Michael's Foundation, and the Max Bell Foundation. Huge thanks to our advisors, Emily Holton, Seema Marwaha, Aaron Plennert, and Twinya Than, and our research coordinator, Miriam Dinesh. Our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or follow me on LinkedIn. I put in a lot of work into these episodes, and I sure hope you're enjoying them. I always love your feedback and your suggestions for other things we can feature. Email us at primary.focus@unityhealth.to with your comments or suggestions. And if you're enjoying these episodes, please do follow us on your favorite podcast app. That way you won't miss an episode. And I'd love your support to get more people listening. You can do this by leaving a review on Apple or Spotify or any other podcast app. We'd also love for you to share this podcast with friends, colleagues, neighbors, because if we really want to build a better primary care system, we need to engage everyone in the conversation. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.